Welcome back, everybody, to One Body. I'm Kruesi.
I'm Eden.
Today we're joined by Carolina Kvietkus. Did I say it right?
Kvietkus, yes. Everyone says it a little different, though.
Kvietkus, yes. Okay, so Carolina and I have a mutual friend is how we got connected. And we also both have Vishlas, and we both live in Atlanta, so we have a lot of connections. But we want to talk today about anxiety. It's a very important topic. Carolina works in family medicine. So can you just tell us a bit about your background, like what got you into medicine, where you went to school, and then how you're enjoying your job in family medicine?
So I went to UGA for undergrad, and I was a biology major, and I had no idea what I wanted to do with that because it was so broad, but I like science.
Mm.
I'm a little science nerd. I was also a Spanish major. So as I kind of got closer to graduating, I was like, I really need to figure out what I'm doing with this. And I wanted to do something that combined the two. So medicine it was. So after I graduated, I was a medical assistant in primary care for a year. I also was an interpreter at a nonprofit clinic that I volunteered at in college. So I got to see a little bit of kind of medicine, just shadowing, that kind of thing then. Then I went to Mercer in Atlanta, 2018 to 2020, and I graduated during the pandemic.
Lovely.
And I went actually back to where I was a medical assistant as a PA now, and I've been there ever since. So I've been there for 5 years. Mm-hmm.
I didn't realize that. That's so fun.
But things were very different when I graduated because it was the middle of the pandemic. So graduation was interesting. And then basically they just said, okay, fly free. We're going to go treat this disease we don't know much about.
I bet that was a wild time to start working. Just like flying by the seat of your pants. Is that the saying?
Yeah, that's how I say it.
Seat. Like, what does that even mean?
It doesn't make sense to me, but I like it.
But I use it.
I do too. I feel like I'm like old person when I say that, but I say it. I love to know, how has the transition been becoming a mom? Because you became a mom, what, 4 months ago?
Yeah, he was born in June. So
Okay.
he's fresh. He's new.
So fresh. How's that been? Is it what you expected? Has it been like a harder transition?
It has and it hasn't. Like, I knew things would be different. I knew I'd be busy. I think the thing was most surprising is how often they eat, or how often you feel like you're feeding them.
Yes.
Because everyone says, oh, it's every 2 to 3 hours. And you go, that's not so bad. But what you don't factor in is that it takes 25 minutes for them to eat, or maybe 40 minutes when they're really little.
Yeah.
And every feeding session, you time it from the beginning of the feed.
Mm-hmm.
So by the time they finish and it's 40 minutes later, if you're doing a 2-hour schedule,
you have
loosely,
an hour 20.
Now you have an hour 20.
Mm-hmm.
And by the time you clean the bottle and run the dishwasher and make yourself a coffee, it's time to do it again. And then factor in also the cluster feeding. Nobody tells you about that. Even the baby classes. We went to one. I don't remember that term coming up at all. And so like it's 3 a.m. I'm on Reddit and I'm like, what is going on? Like, is this kid broken? Like, what is going on? Everyone's like, yes, the cluster feed. Like, why didn't nobody tell me about this?
Yes. He's just hungry all the time. He's just a grown boy.
He was a month early, so he was 4.5 pounds. He was teeny tiny.
Sweet
and he was,
thing.
he had IUGR, so he was also small for his like actual gestational age. So I think for like 10 weeks, he was just catching up. His body was like, I'm literally starving. But he's caught up now. He's like just about in the 40th or 50th percentile unadjusted age.
Oh, that's amazing.
He's on track now.
You've been working hard. You've been feeding.
Yes. So that was a little different than what I expected.
Yeah. So was that a big shock? Did you go into labor like naturally at a month early, or you found out IUGR?
So I knew that I was probably not going to go past 37 or 38 weeks. I had actually really mild cholestasis, which is where you get the bile acids building up in your bloodstream. I don't know if anyone's like doctors ever said, if you have itchy hands or the bottom of your feet itch, particularly at night, you need to let us know. I had that. I only had it for one night, but I was like, that was weird. I happened to have an appointment the next day and they did my blood. And sure enough, I had very mild cholestasis. They didn't really actually do anything about it because I was supposed to see the high risk OB like 1 or 2 weeks later, but I wasn't sure if I was feeling him moving as much. So I took myself actually to labor and delivery, and they did a scan. They found his heartbeat, put me on the monitor, and they were like, everything's okay. Like, nothing's emergent, but we don't love that you're not feeling him move as much. And also you have cholestasis, and also now you have preeclampsia.
Oh,
So,
surprise. Oh my gosh. Wow.
I had actually been checking my urine and my blood pressure at work, and it was
high.
it was subclinical, but I had that appointment coming up and I wasn't technically meeting the criteria for it. So I was like, well, I can keep waiting. It's okay. But by the time I got to the hospital and stuff, I had developed it. So the next morning they did a scan and they were like, ooh, he's tiny. So my chart just kept getting longer and longer of like diagnoses. But basically they said, you don't need to be pregnant anymore. And then they said, well, he's so small, he's probably not going to do well in labor. So we just skipped the induction and went straight to a C-section rather than trying to labor and then probably ending up in an emergency C-section.
Yeah.
We just kind of skipped all that. So he was born the next day at like 1 o'clock in the afternoon.
Wow.
It was like scheduling a haircut. They were like, what time do you want to do it at tomorrow?
That is wild. Gosh, what a whirlwind. I think it's so interesting if people are willing to talk about like their pregnancy and their birth stories, because I don't know, people just don't want to talk about it because it almost feels like something is wrong, or like, I don't know, like it's frustrating to not be able to control it. Like, especially someone like you, who I feel similar to, like we take care of ourselves, you work in medicine, you're big into health and wellness, and then all of a sudden this thing that our bodies are designed to do is actually really hard, and it takes like a huge toll on you. And then you have emergencies happen and you're like, whoa, I've never experienced something like this.
Honestly, getting to 36 weeks, I was just like thrilled.
Good.
And we had a birth plan in the hospital bag, which we had not even fully packed, by the way.
Yeah.
I was like, good planning, Carolina. But the birth plan didn't even come out of the bag. So I think by the time I got that far along, nothing had really gone super smoothly. And so I was just like, you know what? I'm just happy the baby's going to be here.
Yeah.
And so I didn't ever have a ton of expectations on what I wanted for the birth plan. I mean, I think probably going into natural labor is everybody's ideal scenario, but it's almost like a wedding. There's going to be one thing that probably doesn't go perfectly to plan as far as your birth goes. I mean, if it does and everything goes off without a hitch, I'm very happy for you. But just generally speaking, there's going to be a hiccup. I kind of knew that going in.
I'm very happy he's here and you're through that.
He's doing good.
Yes. Now you're moving and grooving. Okay, well, let's jump into anxiety. I want to hear, what's one of the biggest myths about anxiety that you see either on social media or you hear from friends that you think it'd be helpful for people to know that it's not true?
So probably the biggest one I see in my practice is if we are discussing it with a patient and I think they're a good candidate for a medication, which we can dive into what would be, the qualifying factors for that. The person might be nervous about the medicine being addictive. And they'll tell me, I don't want to become reliant on the medicine. There are medicines, particularly a class of medicines called benzodiazepines. Those are things like Xanax or Klonopin, also called alprazolam or clonazepam. Those ones can be addictive if overused or used for longer than what's warranted or appropriate, or if they're taken at high doses to actually cause a high or an abusive kind of situation. But generally speaking, if we're doing something like an antidepressant, those are not addictive. They can be problematic if you are coming off of them. Sometimes people will experience a withdrawal, but a lot of times we can mitigate that. And also, just because you start a medicine like that doesn't mean you have to be on an antidepressant for the rest of your life. So I think that's one thing that people they come in asking me for help. I recommend a medicine, and then they're very nervous that I'm going to give them something that they're going to get addicted to.
Yeah.
And that's just not how the medicines work, at least that family of medicine. And if we do decide to do a Xanax or a Klonopin or a medicine in that family, a lot of times we'll have kind of a separate discussion about the specific risks and how we can mitigate those risks.
That's helpful. Okay. What is the definition of anxiety and how is it diagnosed?
Anxiety can present with mental and physical symptoms. So the mental symptoms might be things like racing mind, impending sense of doom, excessive worry, anxiety leading to insomnia. Physical symptoms, people might have sweatiness, just an uneasy feeling, maybe an uneasy or kind of turning stomach, racing heart, palpitations, shortness of breath. Some of the more unusual, or I guess what people think of as unusual, they're not unusual. They're actually very common. People can feel like their head feels heavy, like they have a hard time holding their head up. People might feel a lump in the throat, or like they've forgotten how to swallow, or like it's difficult to swallow. Sometimes people will get numbness or actually tingling in their hands. Usually it will be in what's called a stocking glove pattern. It will start in the fingertips, and depending on how severe their hyperventilation is, they will get tingling going up the arms, and then maybe even the toes up to the knees, that kind of sensation. So there can be a lot of different presentations. The last thing I ever want to tell someone is who's coming in with racing heart or palpitations, you just have anxiety. It should be kind of worked up. So a lot of times part of the diagnosis is we're ruling things out. So maybe your provider would do like an EKG to check on the heart and make sure that there's nothing actually going on that could be causing maybe an abnormal heart rhythm. Maybe they would check your thyroid to make sure that you're not in a hyperactive state, which can cause many of those symptoms: sweating, racing heart, short of breath. I just listened to your anemia podcast. Anemia can cause shortness of breath, so we'd always want to rule that out. So there's some things that we would want to rule out that we call organic etiologies, meaning there's something underlying in your physical body that's actually causing the symptoms that may be presenting as anxiety, or symptoms that could be anxiety. So part of the diagnosis is ruling out organic causes, but we also will typically do surveys. So kind of self-reported questionnaires. There's a really common one called the GAD-7, which is the generalized anxiety disorder screening. Basically, it asks things like, are you excessively worrying? Do you feel fear? Are you having any sleeping problems, appetite problems? So it's kind of a whole picture that we're looking at to get to the diagnosis of anxiety. But there's other disorders and anxiety disorders out there besides social anxiety. There's panic disorder, generalized anxiety disorder. There's phobias. So think of like arachnophobia, but there's all kinds of phobias out there. One of the more common ones that kind of goes along with panic disorder is agoraphobia, fear of leaving your home generally, but it might be like basically your world shrinks. Maybe you don't leave your neighborhood, or some people don't even leave their room. It can be quite severe in some instances. Children can have some anxiety disorders like separation anxiety or selective mutism. Typically, those are not going to be affecting adults. OCD's another one too, obsessive compulsive disorder. That's where people have anxious or intrusive thoughts, and they'll usually combat those with some type of activity that tends to be repetitive, maybe counting, hand washing, pulling out hair like eyebrows, eyelashes, or on the scalp. To some degree, anxiety on a evolutionary level, it's actually beneficial to us. So it's normal to get anxious, say, if you're giving a speech, or you have a big project coming up, or you're entering some type of stressful situation. But one of the criteria of anxiety is that it has to be distressing to the patient. So it has to be bothersome in the sense that it feels disproportionate to the actual situation. So for instance, maybe you have social anxiety disorder and going out to a restaurant is really anxiety provoking. Logically that there's no danger in going out to a restaurant to be with people, or going to a party. But the problem with it is that you're having all these symptoms as a reaction to something that you basically, logically you shouldn't be. Generalized anxiety disorder is another common one. Typically, you have to be having symptoms for at least 3 to 6 months for the official diagnosis, but it's a generalized worry about many different things in your life. So people will be worrying about work, family, money stress. Am I doing all the things that I should be doing? Am I doing enough exercise? And then they'll kind of ruminate on all these things. Maybe it'll affect their sleep. And they're just constantly worrying about things that they don't want to be worrying about, and they know that they shouldn't be worrying about.
And am I remembering correctly? And the DSM-5 is a book that a lot of the psychiatric disorders can use to have like a textbook diagnosis. Is anxiety part of that diagnosis? Is like the worry is actually keeping them from doing what they need to do, or it's like interfering with their normal functions?
Yes.
Okay.
So that's the qualifying factor of it's distressing to the patient.
Distressing.
So they might just simply feel like, I don't want to feel like this. But a lot of times it does manifest as, I'm going to avoid that situation. Going to a restaurant or going to a party makes me nervous, so I'm not going to do that thing. Or if they have panic disorder and going to the grocery store makes them have a panic attack, they shrink their world and they stay inside their home because they want to avoid the situation that triggers it.
Yeah.
So yeah, it's definitely one of the criteria that you have to have is it's interfering, it's distressing to the patient. Mm-hmm.
That makes sense. Can you talk quickly about the panic aspect? Because can any anxiety disorder, any different subclassification, come with panic attacks? And if so,
Yes.
like what does that look like in case someone listening has ever experienced it?
Yeah. So a lot of times I can walk into a room and look at the person and tell you if they're having a panic attack. But when you're
Wow.
in the middle of it, it's quite scary. Basically, I would say actually probably most people in their life are going to experience at least one panic attack. The question is, how much does it bother you? Some people will have one and they go, that was weird, and they just move on and never think about it again.
Yeah.
Other people, it's really distressing and it triggers something in them where they worry it's going to happen again. And then ironically, that causes it to keep happening again. But a lot of times it can be those symptoms, those physical symptoms that I mentioned, just to the heightened level. So they might feel like their heart is racing, and it might actually physically be racing. And they'll feel like maybe their heart's skipping a beat. They might be having palpitations because they're so distressed and their heart is beating relatively quickly compared to, for someone who's just sitting there at rest. A lot of times people will hyperventilate where they're not breathing enough carbon dioxide out. So they're taking these shallow breaths in and it feels like they can't get a deep enough breath. The heavy head and the trouble swallowing is one of those more advanced symptoms. So that typically tends to go along with panic attacks. Same thing with the tingling. Usually that's if somebody's kind of far along in the hyperventilating. People will report that they feel like they're dying or they're going to die. It will happen oftentimes kind of suddenly, maybe even randomly, like you're not thinking about it. You don't think you're actually anxious. And all of a sudden it just kind of ramps up on you. It's really common for these to actually take people to the ER. A lot of times, not every time, because like I said, we have to work it up. But if you're having chest pain or racing heart or shortness of breath, many times people will land themselves in the ER and the ER will do all the tests and they'll just say, you have panic attack or you have anxiety. It was just panic, which the good news is about panic disorder, as anxiety provoking as it is benign. It's not going to hurt you. It's pretty rare for people to actually fully collapse and pass out from it, but it is possible to hyperventilate to that extent. So it's one of those things where it can be a disorder where it's happening actually repeatedly. Other times it can just be one-offs for people or every now and again for people. But it happens to a lot of people. I think about 1 in 3 people in their life will experience a stint of anxiety at some point. So the lifetime prevalence of it is relatively high.
It's fascinating to me how our minds, and because, anxiety at its core is really just like a psychiatric disorder. It involves the mind, right? But the body becomes so involved. And that's one of those conditions where it's so fascinating to think about like how the mind and the body are talking. And obviously like they're one, like they're connected and there's different signals going back and forth. But like a panic attack is such a interesting like manifestation of what you're experiencing up here and the way that it makes you feel like you're actually going to die. And like your heart is racing.
Oh yeah. And if we checked your blood pressure would probably
through
be
the
pretty
roof.
high.
Yeah.
And you actually are getting flushed and hot. And your blood pressure, if you're far enough along in a panic attack, it might actually be dropping, which might be why you're dizzy and you're about to faint. So there are real physical manifestations of it. And that tends to be the scarier side of it. But like I said, it can be both. So the symptoms can be strictly mental, strictly physical, or kind of a combination of both. So it presents differently in everybody.
And I think it's really important too for people to realize like what you just said, the symptoms are real. Like I think sometimes when people people might feel like they're being like dismissed as having anxiety if they're coming in with really concerning physical symptoms. But it's like, no, anxiety is real. And the symptoms that come with it are real. Like your body is experiencing these things. But what you said, there's not an other organic cause, like where something is wrong with your body. It's just a manifestation of the anxiety. So,
right. As a provider, anxiety is actually always really low down on my differential, especially if people are having heart or lung symptoms. I have to make sure you're not having a heart attack or an abnormal heart rhythm or a blood clot in your lung or overactive thyroid. But once we rule out those things, which are much less common in someone, say, in their 20s or 30s than anxiety, that's where I can officially diagnose you. So we always have to check those boxes off and make sure we're not missing anything actually scary. But if it is anxiety, as distressing and scary as the symptoms are, it's not going to hurt you on a physical level. Yeah. A lot of times too, anxiety, especially to a higher level where if it's happening daily, maybe there's panic attacks going along with it, it tends to lead to depression. So it's a little bit of the chicken and the egg where you depressed first and then that made you anxious. Many times though, if anxiety is the primary concern or the primary issue for the patient where they're saying, I'm feeling nervous, I'm feeling restless, I can't sleep, I'm shaking, I'm sweating, I'm having panic attacks, all that. A lot of times that does lead to depression because people will shrink their world to avoid those symptoms and they just feel so sick of feeling those symptoms, especially if they don't know that there's treatments for it and they're just kind of mudding through it. It can get really, really hard. Actually, pretty quickly, the brain can basically enhance those nervous tendencies, those pathways pretty quickly. And all of a sudden, you can be in a hole where you're having these symptoms very often and it feels like this is just your new life forever.
And that's very depressing.
Yeah, totally. I tell my patients a lot of times they will come in, they've maybe been dealing with this for weeks or months, and I'll ask them, are you feeling depressed? And they're like, I wasn't at first, but I'm just so tired of this. And they'll start feeling pretty down about it. So that's something to always bring up to your provider too, if there is kind of a depressive element to it. It's just something we factor in as far as treatment plans go.
You mentioned about 1 in 3 people will experience anxiety. It feels like to me, anxiety is becoming a lot more prevalent. I think sometimes you'll hear people say like, this is the most anxious generation yet. I don't know if you read the book, The Anxious Generation by Jonathan Haidt, but he was talking about his theories on why like so many kids are now experiencing anxiety. What's your thought on like, one, is it actually becoming more prevalent? And two, what is contributing to that?
The data suggests it is becoming more prevalent. It's hard for me to say because I started practicing during COVID, which is seemingly one of the big inciting events that caused an uptick. Simultaneously, that's also when social media, TikTok, Instagram Reels, like all the like dopamine hit kind of social media was coming out. At least when COVID was going on, I was seeing a ton of anxiety. I think it was just news overload, negative coverage overload. And also people were like losing their jobs. People's lives were just changing overnight. People were having relatives and friends get really sick and maybe even passing away suddenly from this new disease we didn't know anything about. So COVID definitely, I probably if I was seeing 20 patients a day, probably 10 people would be being treated for anxiety. It was actually kind of like wild to see the prevalence just shoot up, at least compared to when I was a medical assistant. I didn't seem to see that much. As far as, I haven't read that book, so I don't know what the theories are, but it does make sense if people are kind of hanging out on their phone more, they're not interacting with people more, they're, maybe not going outside as much. The obesity epidemic is also an issue where people are not getting as much exercise or movement in their day as they should. Also, the foods we're eating, highly processed, they might make you feel sluggish and just kind of run down and cruddy. The other thing I see too is, it sounds funny to say, but like almost caffeine abuse. People are just chugging caffeine, like energy drinks, Celsius, drinking coffee all day. Some people can do that and it doesn't have any significant impact on their mental or physical health as far as they can tell. But there's a lot of people who are pretty caffeine sensitive and they don't always put that together that, hey, if I'm drinking caffeine at 1 p.m. and this is my third cup, no wonder I'm feeling anxious and like I can't sleep at bedtime. So caffeine can definitely be a factor that I'm seeing where we maybe minimize or reduce that, and we can see some reduction in the patient's anxiety level. Also, I don't know if anybody else uses this term. I'm sure they do, but hangxiety, the day after drinking, people will get a hangover and that can spur anxiety. So maybe someone's drinking alcohol, whether or not that's for fun, or sometimes people use it to kind of calm themselves and self-medicate in maybe like a social setting or just a stressful day and they just want to kind of turn off. People will drink alcohol that evening or that afternoon. The next day they wake up with a hangover, they feel sick, they feel kind of cruddy, and it actually spikes their anxiety. And then now they're in a cycle where they feel like they want to drink more caffeine, maybe more alcohol to calm the effects of what they were just experiencing. So then they're in the cycle of not sleeping well, drinking alcohol, drinking caffeine. And so you have this terrible cycle of insomnia and anxiety and caffeine overload.
So that's helpful. Are there any other things that make you more at risk for anxiety? Any other inputs or like genetic?
Family history is definitely strong. It tends to run in families. It's kind of one of those things where it doesn't guarantee you're going to have a mental health disorder or anxiety if a family member has it, but it might be one of those things where you're a little bit more likely or predisposed. So maybe, something occurs in your life that somebody else, it wouldn't bother them. Whereas for you, you're more likely to head down the anxious pathway or tendencies, or maybe even personality wise, you might just be more of a planner or a worrier. In those instances, it could turn into, it might be more likely that you develop one, but it's not a guarantee or a protective mechanism. Even if you don't have a family history, doesn't mean you can't have depression or anxiety down the road.
I think we've covered pretty well, like what anxiety is, the symptoms, how it's diagnosed, what can, make it worse potentially. Let's talk about how you manage anxiety. I'd love to first talk about from more of like a lifestyle, non-medication perspective, and then also what medications you can use.
Yeah, so lifestyle recommendations are always going to be used in conjunction with medication. Medication is a tool. It's probably not 100% of the answer. There's kind of 3 categories that I go off of for people. So lifestyle is the first one. So we talked a little bit about diet, cleaning up the diet probably will help you just feel better physically, especially if you're having a lot of physical symptoms. Sometimes getting yourself feeling better physically can just help the anxiety calm down just because you're not thinking about how your body is feeling so much. Some of that is almost like a hypervigilance. You're over monitoring the symptoms. So maybe if you're having irritable bowel or if you're feeling sluggish and fatigued, cleaning up the diet can help those symptoms maybe not occur so much. And so you're not using energy thinking about those things, worrying about those things. Getting outside and looking at the sun, not directly, but getting some sunlight, getting some fresh air is really good for our nervous system. It can just help the world feel a little bit bigger and helps you not navel gaze so much. It can help you kind of look up, remember that there's other things going on in the world, even just going on a walk in the neighborhood. If you can add some exercise to that, a lot of times anxiety is that uneasy, restless, maybe shaky or jittery, just feel like you can't sit still, you can't calm down, you're having a hard time going to sleep. Getting outside, doing some exercise, burning off that extra energy can actually be really helpful. Having something to direct your energy and your focus onto is also really helpful. It takes you out of that mindset and puts you in a different one. And then we talked about the caffeine and alcohol limitation or avoidance is probably best. Sleep hygiene is another one. I have a lot of, especially like college kids who their sleep schedule is crazy. It's all over the place. They're staying up all night. They're going to bed at weird hours. It changes every day. They wake up at a different time every day. They sleep in all like really late. Having a schedule for yourself can be really helpful for insomnia because your body will fall in tune with feeling what time it is as far as your circadian rhythm. And it can really help you get a good night's sleep. You wake up feeling refreshed. One of the worst things that can happen is if you lay in bed staring at the ceiling all night, you worry all night, I'm not sleeping, I'm not sleeping. How is my day going to go tomorrow? You wake up feeling super tired. You muddle through the day. Maybe you take a nap. Maybe you drink some caffeine, and then you go in your bedroom that night and you look at your bed and you go, the last thing I want to do is try to lay in that bed and go to sleep again.
Yeah.
And it can really spur like a cycle where people almost get anxiety about going to bed. So sometimes we have to use medicine for that to kind of snap people out of that cycle and just get people sleeping. But if you want to do it kind of naturally, having a set bedtime, having a set bed routine, so limiting screens an hour or two before bed, have some type of rhythm, maybe a warm shower, maybe I read a book, doing that at a certain time. And then kind of no matter what happens during the night, get yourself out of bed at the same time every day. No naps. Your body will fall into a rhythm pretty quickly. The other category I always offer to people is counseling or therapy. There are different types of counseling or therapy you can do. As far as I know, the most well-studied one and highly recommended one in anxiety disorders is cognitive behavioral therapy. So basically what CBT does is it sort of retrains your brain to think about things in a different pathway. So a lot of times when people are having anxiety day in, day out, they feel very stuck. They feel like they're in a loop. They feel like they're thinking the same things over and over again, and they don't have any control about it. CBT, what it does is it trains you and gives you power over your thoughts and over how to think about situations. Sometimes some exposure therapy might be involved in that too. So let's say someone is having panic attacks with driving. We might go driving with our therapist. Maybe not on the highway at first. Maybe we just look at pictures of cars. And then we move slowly towards the thing that we're fearful of. A lot of the data suggests that medications in conjunction with therapy and lifestyle is more beneficial and has a better prognosis than just one of those three alone. So counseling therapy is another kind of category of treatment. And then the medications is the other one. And that's kind of where I specialize, or like your general PCP or a psychiatrist, we would be the ones doing the medication management.
Let's talk about the meds. What are the options? What do you like? What do you see the most benefit from? Or is it just totally dependent on the patient and what kind of anxiety they're having?
So once we've kind of put our thumb on what's going on, we're going to be factoring in all those different things. What's your lifestyle? How are your symptoms presenting? How long has this been going on? What's your family history? Have we ruled out all the other things organically that it could be? Usually we have to consider, should we just do lifestyle or therapy, or should we also introduce a medicine? That's going to factor in things like, how long has this been going on? What is the severity? Do you want to do a medicine, or do you want to just try counseling alone? If we get to that point where we're thinking medicine is going to be part of our treatment plan, the first line is going to be SSRIs, or selective serotonin reuptake inhibitors. They have a cousin to them that are called SNRIs, serotonin norepinephrine reuptake inhibitor. So they're similar, but they do target different, basically, neurotransmitters. But the first line treatment is usually the SSRIs. So maybe people have heard about Zoloft, Paxil, Prozac. Those are kind of the common ones. These are medicines that you take every day. So these are not immediate acting medicines. We have to wait for it to get into your system, which can take about 2 to 6 weeks. Typically around 3 to 4 weeks, people will maybe start feeling some benefit from the medicine, but it can take up to 6 weeks to reach its full potential. When you start taking that medicine, sometimes you can have kind of what I call onboarding side effects, or transient temporary side effects. Your body has never seen this medicine before, so your body has to get accustomed to it. Sometimes people will experience headaches, maybe some upset stomach. All these symptoms, they tend to be kind of minor, but a lot of times if they're not really intense, I'll tell my patients, if you're having these symptoms, push through. Usually by week 2 or 3, your body has become accustomed to the medicine and those side effects will dissipate. I don't tell people to suffer. If you're miserable on the medicine, we need to move on. But if it's just kind of like annoyance, keep going. A lot of times that tends to go away. There is a rare side effect of suicidal ideation. If you are first starting an SSRI, it tends to happen in the first couple of weeks being on the medicine, if it's going to happen. Again, it's very rare. It tends to happen to younger patients. So adolescents, early 20s. I don't tend to see it in 30, 40-year-olds. And so I always tell my patients, look out for any major mood changes. If you're having any suicidal ideation or self-harm thoughts, and it's in relation, like you just started the medicine a week or 2 or 3 ago, stop the medicine, call 911, call 988, let our office, know about it. And you have to get evaluated by like emergency psychiatry if that happens. Yeah. But that's one of the more scary potential side effects. But again, it's quite rare. So usually I'll follow up with my patients after about 2 to 3 weeks of being on the medicine, see how the side effects are going, see if they're getting any benefit. A lot of times too, I'm going to start them on the lowest dose just to get it in their system and mitigate the possible risks for having those side effects. And if usually everything's kind of going swimmingly on week 2 or so, I'll increase the dose to maybe the next dose if we need it, or sometimes I'll actually start them at a lower than FDA approved dose, and then we'll bump up to what's the lowest FDA approved dose. Then at that point, I'll follow up at about maybe 3 or 4 more weeks later. So they've been on the medicine for 6 weeks roughly. And we'll kind of reassess. We'll do inventory. I know we talked about some of those temporary or short-term side effects of the SSRIs. There can be long-term side effects of the SSRIs. So side effects that don't dissipate as you're on the medication, meaning basically for as long as you're on that medicine, you may experience that side effect. I would say the main one that affects probably about 80 to 90% of people is sexual side effects, which some people really find quite distressing and they just don't like it. There is a medicine out there that's similar to the SSRIs that is FDA approved for depression, but not anxiety, but we see it used in anxiety. It's called Trintellix. It was designed to not have those sexual side effects. So some people do really well. They get the best of both worlds where they're not having that side effect and it works for their anxiety. But you have to kind of talk to your provider about. It's also usually not covered by insurance unless you've tried other antidepressants, and it can be quite expensive. So a lot of times just because of insurance reasons, I'm still reaching for those SSRIs. Other side effects people can see are maybe appetite changes, high or low. It can go both ways. And then weight changes. The SSRIs, if anything, tend to be either weight neutral or weight positive. And they're all different. They all kind of fall on a sliding scale. Paxil is the most likely to cause weight gain. I would say Zoloft and Lexapro are the 2 that I use most often because they tend to be the most weight neutral. Some people also will report vivid dreams. If they're not nightmares, I don't worry about them. If they're not distressing, it's just kind of a weird thing that you might notice. But vivid dreams is another one that people will sometimes bring up. There are other medicines out there though. So sometimes people, when I tell them this medicine is going to take 2 to 6 weeks to kick in, they're thinking, I cannot keep doing this for 2 more weeks, even, let alone 6. Mm-hmm. So there are some faster acting medicines that sometimes will layer on top of your baseline daily medicine that have a quicker action, and we'll use that as a bridge. So our goal for those is not for you to be taking those every day like your SSRI, but maybe you need them to get you to the point where the SSRI is kind of kicking in. And then after that, maybe you need them occasionally. Maybe you have a bad day, or maybe you have, a speech you're giving, or you're going to go into a situation, that it's going to trigger you. We'll use those as needed medicines kind of sparingly. Our goal, though, is not to be treating you with an as-needed medicine every day. If you're taking or reaching for your as-needed medicine on a daily basis, you need something that you're going to take daily instead of reaching for something that only works for 6 hours 4 times a day. But a lot of times when we are doing that transition onto the SSRI, people will be taking their as-needed medicine quite frequently. They'll notice, though, that naturally, as time goes on, if we're on the medicine that's going to work for them, they just kind of naturally back off of it, and they look back, at the past couple weeks, and they go, "Oh, I'm not taking my as-needed medicine so much anymore." The as-needed medicines are several different categories. Sometimes it's a sleep medicine, maybe a antihistamine like hydroxyzine, maybe an old school antidepressant that doesn't actually work that well for depression, but it works for sleep. Trazodone, people might take those before bed. Sometimes we might give what's called a beta blocker, propranolol, it's a blood pressure medicine that's not very good at treating blood pressure, but it does slow the heart rate down. So people will sometimes take that for test taking anxiety before they're taking an exam, or they'll take it before they're getting a speech. It'll help with voice tremor and shakiness and their heart racing and flushing during a speech. We also, kind of backtracking, when I mentioned the Xanax and the Klonopin, if the symptoms are quite severe, people are having regular panic attacks, they're really intense, we'll maybe do a Xanax or a Klonopin kind of short term, or try to use it very sparingly. The Xanax or Klonopin are higher risk medicines than those other categories of treatments because they can be abused. So the longer you take them and the more frequently you take them, that risk can increase. We just have to always discuss the risks and how to use that medicine properly.
Do you ever use Buspar in that category?
I do. So some people with Buspar finds that it gives them almost like a buzzing kind of headache. That's the main complaint. It's a little bit of a toss-up for me as far as success, because a decent chunk of people have that buzzing headache side effect and they don't like it. And so we nix it. So it's not usually the first one I go to, but it is an option. Usually the SSRIs are my first go-to. A lot of people will live with these symptoms thinking that this is just how they are, or, oh, this was in my family, so this is how I'm destined to be. Or I've tried a medicine, it didn't work. That's all there is out there. I will probably try people on, I would say maybe 4, 5, 6 medicines before I refer them to a psychiatrist. Granted, that's probably a lot more than what a typical family med doc would be willing to do, but it's because I just see it so much. I'm pretty well versed in it, and I feel really comfortable with all the different medicines. But whether or not you're seeing your primary care or a psychiatrist, you're not out of options. There's a lot of different treatment plans. If you look at anxiety as a tree trunk, the 3 main branches are lifestyle, therapy, medicines. And then off of those branches, there's many different limbs where we can pull different things and ideas and treatments. So just because you've tried 1, 2, maybe even 3 things, I got plan A, B, C, D, E, F, G for you, and if I can't figure it out as your primary care, if your primary care isn't sure what to do next, ask for some blood work, ask to test your thyroid, test you for anemia, maybe check a vitamin B12, make sure nothing is getting missed, and then ask for a psychiatry referral. Go see the person who does this all the time. And if you're a psychiatrist, you don't get on with them, you're not getting answers, get a second opinion. There's nothing wrong with getting a second opinion. You're not going to hurt your provider's feelings. I know it's a lot of work sometimes to go do that, but a lot of times we can get the treatment plan that's going to work for you. I would say in family medicine, I probably have about a 70 to 80% success rate in getting people satisfied with their treatment plan. So there's a more likely than not probability that your primary care can at least get you some benefit and get you in the direction that you want to be going with your treatment plan. So I would say that's kind of the big takeaway. Don't wait. Go talk to someone about it. You don't have to live feeling nervous and on edge and like you're spiraling and spinning and not sleeping. There's things we can do. Don't be afraid of medicine. If you need medicine, you need it. Just because you're on medicine for a stint of time does not mean you're going to be on it for the rest of your life. Some people are just wired that way. They do better on medicine. That's not everybody. Some people just need it for chunks. They just need it for seasons.
And like you said, kind of to get them out of maybe that mental spiral. Like maybe they just need it to help them sleep for a few months, or they're postpartum and they have crazy anxiety because they're postpartum and they need it for 3 or 4 months. And, you know, then maybe that mixed with ongoing lifestyle changes and counseling, then you could potentially wean off.
A lot of times people will spiral into the anxiety and the panic. It starts off kind of mild and then it's happening. And so it's concerning and worrying and they don't like how they feel. So it spirals more and more. Same thing once you start feeling better. A lot of times you can up spiral out of it. You start feeling better. You start looking on the bright side of things. You start seeing some improvement. So you feel motivated. So there's a lot of reasons to go get treatment. Treatment begets treatment and getting better. Yeah. Whereas staying in it, a lot of times you kind of it can just eat away. It can get worse and worse relatively quickly for people. So go get treatment. And there doesn't have to be an inciting incident for it. Sometimes it just happens. Sometimes it just happens. It doesn't have to be in relation to anything. Like I said, you're not the only person who's had this or will have this. Probably everybody you know at some point will have some level of anxiety going on in their life. Super common.
Yeah. I like the idea of the bridge, like whether it's medication or some kind of treatment to bridge you to a better place. And the up spiral, that is an amazing picture.
Yeah, not everything has to be forever. A good therapist will work themselves out of a job because they'll get you to the point where you don't maybe need therapy anymore. Yeah. Same thing for the medicines. You know, maybe you need it for a chunk of time, but my goal as your provider is to get you on as few medicines and have you have as few spikes of anxiety day to day with as minimal intervention as we can. But a lot of times it's on the patient, you know, doing the lifestyle modifications, but then also making sure you're following up with your provider and giving them feedback on how things are going with each step that you're taking.
That makes sense. Well, that was so helpful. Thank you so much, Carolina. As a disclaimer, all this information is for educational and entertainment purposes. It's not supposed to count for medical advice. So you should always go see your provider if you have questions about your health. But hopefully you learned something interesting about anxiety. I'm sure we've all experienced it. So thank you so much for taking the time. We really, really appreciate it.
Thanks for having me on the pod.
Yes.
My first podcast.